Hello everyone, we are starting our hematology chapter, that is blood. We will be discussing the following topics which are important. These are the blood, then we will discuss the investigation options, introduction of hematology, the iron deficiency anemia, megaloblastic anemia, hereditary spherocytosis, aplastic anemia, then idiopathic thrombocytopenic purpura, then hemophilia, then leukemias. CML, that is chronic myeloid leukemia, polycythemia vera, myelofibrosis, Hodgkin lymphoma, and multiple myeloma. Now, coming towards our first topic, we will try to cover this unit in two videos. Okay, so the first topic that we will be discussing is iron deficiency anemia. We are having a scenario that there is 30 years old farmer with past history of peptic ulcer due to prolonged use of NSAIDs, presented with palpitations and easy fatigability from the last 2 months. On examination, he is anemic, no lymph node enlargement, no body tenderness, no splenomegaly. HB is 7 gram with normal WBC and platelet count. Another scenario is that there is a 36-year-old multiparous female who is increasing pallor, tiredness, and palpitations for 1 year is present. HB is 8 gram, total leukocyte count is 8000, MCV is 50, and serum ferritin is 10 microgram per liter. Normal value is 15 to 400 microgram per liter. The cholinergia is present. So, what is the diagnosis, investigations, and the treatment options? The causes of the anemia are dietary lack, that is both in children and elderly, then increased utilization, that is in pregnancy, in lactation, and in children, impaired absorption, celiac diseases, gastrectomy, and blood loss, that is GI blood loss. The clinical features of iron deficiency anemia are koilonychia, that is nail spooning, angular chelosis, atrophic glossitis, pica, that is consumption of non-nutritive substances such as ice and clay, and brittle nails. Okay, we are having a Plummer-Wilson syndrome, which is iron deficiency anemia, esophageal web, atrophic glossitis, increased risk for squamous cell carcinoma of the esophagus. The investigation options for iron deficiency anemia are complete blood count, that is CBC, microcytic anemia, that is MCV is less than 80, and thrombocytosis, that is increased platelet count. Then the iron profile is done, which is serum iron, decrease serum iron, then total iron binding capacity increase only in this anemia. Decrease ferritin, that is best single test to confirm iron deficiency, then decrease transferrin saturation, which is less than 15%, and soluble transferrin receptors, which is increased. Then H. pylori antigen is done. It is done in stool examination, and the GI endoscopy is done to see the ulcer and biopsies. The treatment options for iron deficiency anemia is iron replacement, that is ferrous sulfate 200 mg 8 orally, ferrous gluconate 300 mg 12 orally. Avoid aspirin, avoid PPI. If omeprazole 40 mg is given, blood transfusions are done, which are packed cell volume. Intravenous injection of iron if can't take orally, intramuscular sorbitol, intravenous sucrose. Total iron deficit, that is body weight in kgs into 2.3 into target HB. Actual HB into 0.25 plus 500 ml. This is the total iron deficit of the body. So we have discussed the topic iron deficiency anemia. We have discussed the scenario that there is the past history of peptic ulcer and history of NSAIDs use, palpitations and easy fatigability is present, anemia is present, there is no lymph node enlargement, no body tenderness, no splenomegaly, and HB is 7 gram. So this is iron deficiency anemia. Then we discuss the different causes, then the clinical features, then what is Plummer-Wilson syndrome, then we discuss the investigation options, which are complete blood count, that is CBC, then iron profile, which is serum iron, total iron binding capacity, decreased ferritin, decreased transferrin saturation, and soluble transferrin receptors, H. pylori antigen, and GI endoscopy. Then we do the treatment options, which are iron replacement, avoid aspirin, PPI, omeprazole is given, and blood transfusions are done. Coming to our next topic, that is megaloblastic anemia, vitamin B12 deficiency anemia. We are having a scenario that there is a 25 years old male presented with numbness and paresthesia of the hands and feet with progressive difficulty in walking for the last 8 months. Okay, presented with numbness and paresthesia of hands and feet with the progressive difficulty in walking for last 8 months. Recently, relative had noted some behavioral changes with memory impairment, and on examination he is anemic, loss of position and vibration, sense in lower limbs with ataxia, gait, and lab shows HB 6 gram per dl with MCV of 110 femtoliter. So what are the diagnosis, investigation, and treatment options? Vitamin B12 is present only in foods of the animal origin. The causes of vitamin B12 deficiency are decreased intake, malnutrition, and pure vegetarian malabsorption, that is, decreased intrinsic factor, decreased pancreatic insufficiency is there. The Crohn's disease is the cause, bacterial overgrowth, and diphyllobothrium latum. These are the causes of the megaloblastic anemia. The clinical features of megaloblastic anemia are fatigue, weakness, lemon tints to skin due to combination of the glossitis, angular chelosis, pallor and jaundice. Neurological findings are there. Peripheral neuropathy is present and decreased vibration sensation is present. The definition of the megaloblastic anemia is that it is characterized by presence of erythroblasts in the bone marrow with delayed nuclear maturation because of defective DNA synthesis. These erythroblasts are large in size, therefore called megaloblasts. The investigation options for megaloblastic anemia are doing CBC, which decrease serum B12, not reliable, increase homocysteine, increase urine methylmalonic acid, which is the most sensitive test, decrease reticulocyte count, increase LDH, and indirect bilirubin levels. The first aid treatment for the megaloblastic anemia is that first to do best initial test, which is CBC with smear, elevated MCV, and hypersegmented neutrophils, then B12 and folate deficiency identical hematologically and on blood smear, then B12 deficiency, that is increased MMA and homocysteine, folate deficiency, which is normal MMA and homocysteine, and the bone marrow is done, which samples reveal gained neutrophils and hypersegmented. Radiological beta 12 in urine is done, which shows the dietary B12 deficiency and no radiolabel beta 12 in urine, considered pernicious anemia, bacterial overgrowth, pancreatic enzyme deficiency. The treatment options are general measurements, which are blood transfusions, FHB is less than 4 gram per dl, treatment of the infections, and packed platelets if present with purpura, and drip intravenous is used. The specific treatment for megaloblastic anemia is 1000 microgram vitamin B12 intramuscularly in 5 doses is used 2 to 3 days apart, followed by maintenance therapy of the 1000 microgram every 3 months for life. Neurological abnormalities are reversible if treated within 6 months, and sensory neuropathy may take 6 to 12 months to correct. Blood transfusions if less than or equal to 4 gram per dl, and packed platelets if present with purpura. Patients with pernicious anemia are treated with parenteral therapy, injection vitamin B12 1000 microgram daily for first week, and then weekly for first month, and monthly for life. So we have studied the topic vitamin B12 deficiency anemia or megaloblastic anemia. We are having a scenario that there is a patient who feels numbness, paresthesia of hands and feet, and progressive difficulty in the walking. Recently, relatives have noted some behavioral changes with memory impairment. On examination, anemic, loss of position and vibration, sense in lower limbs with ataxia, gait, and lab shows HB 6 gram per dl with MCV of 110 femtoliter. So we have discussed the causes, the clinical features, the definition, then the investigation options, which are CBC. First aid, that is best initial test, beta 12 deficiency, folate deficiency, and bone marrow. Then radio labeled B12 in urine, then no radio labeled B12 in urine, and then the treatment options, which are general measurements and specific measurements. Now coming towards the next topic, that is hereditary spherocytosis. We are having a scenario that there is a 23-year-old male presents with tiredness, fatigability, weakness, and pain, right hypochondrium. On examination, having pale conjunctiva, jaundice is positive, and tender right hypochondrium with splenomegaly is present. HB is 9 gram percent, and total leukocyte count is 11,000 per cc. Platelets are 1,90,000. Serum bilirubin 5 milligram, LT 35, and ultrasound abdomen shows multiple gallstones. So, what are the diagnosis, the investigation, and the treatment options? The definition of hereditary spherocytosis is that it is an autosomal dominant disorder with intrinsic defect and extravascular hemolysis. The clinical features of hereditary spherocytosis are recurrent episodes of hemolysis, intermittent jaundice, positive family history, moderate splenomegaly, that is pigmented black gallstones, and crisis, which are hemolytic crisis, aplastic crisis, and megaloblastic crisis. The investigation options for hereditary spherocytosis are blood CBC, which is the best initial test, decrease mean corpuscular volume and increase mean corpuscular hemoglobin concentration. Then blood smear is done, which shows spherocytosis. Then eosinophil 5 is done, uh, which is the most accurate test, and acidified glycerol slices test is done, which is the most accurate, and CBC is done, which shows increased HB and reticulocytosis. Bilirubin will be raised, that is urobilinogen, and osmotic fragility test is done, which shows the spherocytes rupture in hypotonic salt solution. Spherocytes increase MCHC negative Coombs test, and osmotic fragility will be present in the megaloblastic hereditary spherocytosis. The treatment options for hereditary spherocytosis are splenectomy, which is curative. It improves but not normalized. The blood transfusions are done in hemolytic crisis, and folic acid 5 mg per daily is given. So we have discussed the topic hereditary spherocytosis, its scenario, then the definition, then the clinical features of the hereditary spherocytosis, then investigation options, which are blood CBC, blood sphere, eosin 5, acidified glycerolysis test, CBC, bilirubin, osmotic fragility test, and then the treatment options, which are splenectomy and blood transfusion and folic acid. So in this video, we have discussed the three main topics from the hematology, uh, which are the introduction, then the iron deficiency anemia, then the megaloblastic anemia, then the hereditary spherocytosis. In the next section, we will discuss our next four topics, that is aplastic anemia, idiopathic thrombocytopenic purpura, and hemophilia and leukemia. Thanks for watching.